Before talking about stroke, it is necessary to have a brief anatomical reminder of the cerebral vascularization. This last one is ensured by the internal carotid artery in the anterior region and the vertebral artery in the posterior region, which join together to form the circle of Willis. The internal carotid artery divides into the anterior cerebral artery and the middle cerebral artery. The vertebral artery ascends along the spinal column and enters the skull. The two vertebral arteries join together to form the basilar artery, which supplies blood to the posterior part of the brain, including the brainstem and the cerebellum. Now let's talk about stroke. A stroke is a sudden onset focal neurological deficit of vascular origin. About 80% of stroke are of ischemic origin, and the left 20% are hemorrhagic. The average age of stroke occurrence is 73 years old, 70 years for men and 76 for women. The etiologies are mainly dominated by atherosclerosis in the elderly patients. Embolic heart diseases and carotid dissections are common causes in young individuals. Now let's talk about the diagnosis approach. During the clinical examination, it's important to gather all the information through a throughout history-taking process. This includes assessing the presence of cardiovascular risk factors such as age over 55, the existence of hypertension or diabetes, smoking or alcohol consumption, as well as dyslipidemia. Additionally, it is crucial to inquire about any relevant past medical history, including prior strokes, a history of an embolic heart disease, or a coagulation disorder that can increase the risk, plus any use of anticoagulants. The possibility of cervical trauma should also be considered, as it may indicate cervical artery dissection, especially in young patients. The functional sign and focal neurological deficits that a patient might present with can vary depending on the location and the size of the lesion. For instance, the involvement of the anterior cerebral artery can result in the contralateral weaknesses of the lower limb, mutism or inability to speak, attention deficits, sphincter dysfunction, and some other symptoms. In cases of the involvement of the middle cerebral artery, the symptomatology depends on the dominant hemisphere. It can manifest as a contralateral hemiplegia with a predominance in the face and the upper limb, superficial and deep hyposthesia, which is a reduced sensitivity to touch, or proprioceptive sensation, which means the patient cannot sense the direction of his hand with eyes closed. Visual field loss on one side can occur in some cases. The involvement of the posterior cerebral artery can lead to complex visual disturbance and impaired vigilance and memory deficits. It is important to note that there are other signs specific to each territory, and sometimes these signs can coexist. In the diagnosis approach, it is important to emphasize the time and the mode of the onset, as they are essential for appropriate management. A transient ischemic attack refers to symptoms that regress within 24 hours, while a completed ischemic stroke reaches its maximum severity within 1 hour and lasts for more than 24 hours. These time frames play a significant role in determining the appropriate course of action for treatment and intervention. Several evaluations should be carried out throughout a clinical examination. This consists of blood glucose measurement. It is important to check blood glucose levels, as hypoglycemia can mimic stroke-like symptoms. Therefore, it's important to exclude hypoglycemia. Check out vital signs. The measurement of respiratory rate, oxygen saturation, heart rate, blood pressure, and body temperature should be done to assess the patient's overall condition. A thorough neurological examination is essential. The National Institute of Heart Stroke Scale is commonly used to evaluate the severity of stroke. These scales assess various neurological functions, such as consciousness, motor skills, speech, and visual disturbance. Finally, a cardiac examination should be performed to identify any abnormal health sound that may suggest a cardiac source of an emboli. These examinations help to gather all the important clinical information to aid in the diagnosis and the management of the stroke patient. Furthermore, there are some other paraclinical examinations that are necessary to distinguish between ischemic and hemorrhagic strokes. The first one is brain MRI with diffusion weighted imaging, or DWI. It is the gold standard for examination, and it can show ischemic lesions as hyperintensities very early, even within the first few minutes. This allows for a quick confirmation of an ischemic stroke diagnosis, especially in cases with atypical symptoms. The hyperintensity of DWI typically resolves within 2 to 3 weeks. We can do another sequence called T2 flare, which can detect hyperintensity after a delay of 4 to 6 hours following the onset of an ischemic stroke. The presence of an extensive lesion on diffusion weighted MRI indicated that the brain tissue can be solved and may benefit from thrombolysis. The T2 sequence can reveal recent hemorrhages and hemorrhagic strokes. When available, magnetic resonance angiography is performed for etiological diagnosis. If an MRI is not available, a non-contrast brain CT scan can be performed. In cases of a hemorrhagic stroke, spontaneous hyperdensity can be observed in the brain. Initially, in the ischemic stroke, a CT scan may appear normal, highlighting the importance of an MRI. Possible early signs on a CT scan includes arterial hypodensity indicating a thrombus inside the artery, and a loss of differentiation between gray matter and white matter in the affected area, of course. Additionally, complementary tests may be requested based on the suspected etiology and the patient's age. Thanks for watching, and I'll see you in the management of stroke in part 2.